Oh, you're not in present, you're not in presentation. Yep,
Is that better?
perfect.
Sorry, friends. Every time I open and close my laptop, the gremlins come out and things go wrong the next time I try and use things. Um, Thanks for joining us this Friday. We are going to spend most of our time talking about what the federal administration is doing and also what states are doing because there's a lot of activity related to Medicaid. And using fraud as a reason to cut services, specifically home and community-based services. So lots of developments, some of them very serious, that we're going to focus most of our attention on today. We will just briefly say that now that the assembly session has ended in the state legislature, there is this kind of in between time before the Senate meets again, but it doesn't mean that nothing is happening. This week, the Joint Finance Committee did meet, and they did schedule a hearing on 1310 requests, which again are requests that state agencies make when they do not have enough funding to run the program as the legislature has directed. So the Department of Workforce Development has submitted a 1310 request because they do not have enough money to serve everybody who needs help for the Division of Vocational Rehabilitation. And over the past several weeks, we've talked about how advocates are making a case that because of that lack of funding, it is meaning that people who want help to get a job are waiting for that help and waiting up to a year. And that wait list will continue to grow because the money that the legislature set aside was not enough to serve the number of people who need the service. We are now up to more than 5,000 people who are waiting. And even if the money came tomorrow, it would take a good amount of time to work through all of those people who are already waiting. And advocates have made the case to joint finance that this is an immediate need that can be fixed, that would put us in a better position the next budget cycle to be funded at a level that was meeting the need from this cycle before we go into the next budget, where again, we would expect that there might be a lot of debate about cuts in services, et cetera. The legislature has heard that message, but DVR's 1310 request was not on the meeting schedule that Joint Finance set this week. So that request continues to be unfulfilled. And we are now approaching where there is probably maybe one more meeting for Joint Finance. Generally, they will meet while the Senate session is going on. And then once the Senate session closes, while they still can meet, it becomes far less likely, especially in an election year. So we're now kind of down to the wire on that request. And either they are going to schedule 1310 and approve that request, or we are going to see that wait list continue to grow and become more significant. The other thing the state Senate is doing is deciding which bills that have already passed the Assembly they are going to schedule a vote on in their last session days in March. And again, things that have already passed the Assembly are kind of the list of things that are still left that could become law because the Assembly isn't meeting again. So there are several items that are important to people with disabilities, either that we would want to see the Senate act upon, or we would rather the Senate not act upon, that are going to be kind of on that list of what gets done or not done in the next couple of weeks. The food share funding, the Assembly did pass that, and it is attached to a bill called AB 180 that makes some other policy changes to food share. If the Senate doesn't act and pass that bill, then the funding food share needs to comply with all of the changes from HR1 doesn't pass. So that has become a bill that really needs to make it over the finish line. There's a separate bill, AB 253, that's made it through the Assembly, and its fate is less certain in the Senate. And it's a smaller bill, but it would let people who are in the Medicaid Assistance Purchase Plan, which is the work incentive program for people with disabilities, and allows them to earn and save more while still maintaining their eligibility for Medicaid. It would allow them to inherit a lump sum of money without losing their eligibility for Medicaid. And for some people, that's a pretty big deal. So again, the Senate has the opportunity to either act on that piece or not. And if they don't act, then it can't become law this session. There's one bill that would let hospitals pick decision makers that aging, disability, and legal advocates really are opposed to, because they have many, many concerns about what that would mean in terms of patients losing their civil rights and never getting them back, and the potential for people to be subjected to basically fraud, waste, and fraud and abuse, and other consequences that would be very hard to undo. So that bill would die if the Senate doesn't schedule a vote. And so that's, if you're looking for messages about do these things, don't do this, that's kind of the way we're subdividing how we're thinking about what senators should hear in the next couple of weeks. There are bills that are still being introduced. Even they can't become law this session. The Assembly has ended their session, so there's no more Assembly public hearings. Like, the process that the bill needs to go through can't happen because the Assembly has ended its session. But that doesn't mean that you aren't going to still see ideas and bills being circulated for co-sponsorship and introduced. Sometimes legislators want to introduce bills that they know can't pass because there's no pathway to do so, because they're trying to communicate a position or an idea or something they feel strongly about. Oftentimes it may be an idea they feel very strongly about that they want voters to know what they think about it. So you'll see, like, in this time period, bills introduced, and then like maybe a lot of pop-up press conferences at the Capitol trying to promote essentially the ideas. And they're trying to hold up and say, hey, we want to do this as a flag that says, if these are ideas that we have, and if we were in charge, we would do these things, right? Sometimes legislators have been working on ideas for the whole 2-year period, and they want to get them out there because it's a very clear signal that this is a piece of legislation they really champion and they're intending to introduce again. And it's very common for the same bill or a bill that is maybe slightly different, but on the same idea, to be introduced many times. And sometimes a bill might be introduced 10 times before it really has a pathway to move forward. So there are definitely also, when you're watching the list of bills that are coming out, also ideas that when you see them, somebody is saying, hey, when I come back next session, this is going to be one of the first things I introduce next January, right? It's kind of a signal. And we'll talk about one of those bills that has been introduced multiple times, just because I think it will be something to watch again. This week, there was a bill that would make assisted suicide legal in Wisconsin that will be introduced. And there are lots of advocates who have been watching legislation in other states be introduced and passed. And I think there's some reason to pay attention to it in the current climate. So just briefly, the bill that was introduced lets people who are over age 18, who are mentally capable, who have a terminal illness, request medication for the purpose of ending their lives. And lots of times when I hear legislators talk about this kind of legislation, they have a very specific picture of who they think is using it, and they have a very specific personal connection to to the idea. In other words, maybe they have a relative who has a fairly significant degenerative disease like ALS, for example, or they have a person who has, undergone a lot of medical challenges. Often these are people who are older, like older relatives, and they project kind of some of those personal things like I know he didn't want to live like this, or I wouldn't want to live like this, and insert the example. And they're coming from a frame of what do they think they might want to have the option to do if they were in the situation, and or they knew somebody who they think would have used this option or have said that they would have wanted that option, that they've had in their life. So oftentimes this issue is approached mainly from an aging perspective, and also from the perspective that it is the individual who is actively making that choice in only the context of the medical condition, as opposed to the larger reality that many caregivers and folks that work with aging and disability populations understand. Um, there are a number of states that have passed variations of laws. There are some countries that already have some these laws in place. Canada is one of them. And so we have some people who, like states and countries that have gone before us. And what lots of advocates in this space can say is usually the laws start in one place and then they kind of evolve to be more and more expansive. Um, and because this has been an idea that has been kind of out there for many years, the landscape and the context in which these bills are being considered now might look very different than it did when some of the first examples went into place. And I think one of the things that advocates are really paying attention to is that while this particular bill and idea has been introduced in Wisconsin before, the current moment that we are in and the pathway, the likely direction of how healthcare and long-term care is going, causes us to have some real concerns that there might be more people who might not want to end their lives, but see a reason to do so because of the larger context of how we do health and long-term care in this country. And indeed, in Canada, there has been a movement that people with disabilities, as they lose unpaid caregivers in their lives and do not have the appropriate system of supports in place, are requesting to end their lives more often because the service system is not able to facilitate their life, to continue in a way that they feel is appropriate. So, this idea, while it is implying that it is one individual making a choice only thinking about their medical context, generally people make decisions based on a whole wide variety of factors. And those factors can include costs, right? How much does it cost to treat a particular thing? How am I at risk of going into a nursing facility that I might not want to be in, or that costs a lot of money, that might put my family at risk for medical bankruptcy, or might make me lose all of my assets and my property that I had hoped to pass on? Like this is a piece of context that could be influential in making those decisions. And certainly lots of advocates have seen that things have become harder in that space. Health costs are higher. Long-term care is, especially if you need nursing care, is harder to get and more expensive. I am old enough to remember before the Affordable Care Act when this was a reason why people would not do treatments. So we have some experience of, when costs are too high, how does that factor into decision making? I also think that some of what we're going to talk about later in this presentation, the current threats to the home and community-based services that are keeping people comfortable and in their homes and where they want to be and are really enabling people to live well rather than just survive. Um, those are at risk. And for a lot of people, those systems are already fragile. They might not provide all the support they need, and perhaps their support system is fragile as well, as unpaid caregivers and are aging themselves. So that we have seen in other countries has been a factor for requests for assisted suicide, is that the conditions in which the choices are very stark for people. If you want to live, you do not have access to the things that will help you do that well. And so a lot of folks are exploring other options. There are also people who have, and we see this in other countries, while it is supposed to be the individual's decision, there's definitely folks that have experienced a bias towards people with ongoing or chronic conditions or disabilities. And in some countries, people who have disabilities are kind of almost steered towards these options because there's an assumption sometimes by the medical professionals that, well, of course, you might want to consider this because of your disabilities. And there's certainly the opportunity for coercion, um, you know, overtly, but also just pressure. People with conditions know that they rely on other folks for help. And so, those feelings of being somebody who relies on help and the impact on the helpers sometimes is also a factor that these bills aren't meant to consider. They're kind of trying to set up a parameter and an idea that there is a pure choice that's only based on one thing, when the reality is often more complex. So a little more than I would normally spend time on this kind of bill, but I think it's important, if you have strong feelings about this, to kind of prime the legislature with what your thoughts are, because I do think that as the context and the landscape changes in health and long-term care, the potential for risk or steering or people making choices because the systems we have are not good enough, or not there, becomes greater. I am going to skip through the rest of the state stuff, but I have left the slides on like food share and the patient representative bill and the action steps so you can refer back to them later, and take this week's actions if you have not done so already. One small hover point before we go on. This week, the governor also did a press release calling for a special session, this time on a bill for redistricting. There's still rumors about, will there be a special session called for a kind of a grand bargain of spending increases as we reduce revenues. We don't know if that will happen. In the past, the governor does have the ability to ask and call for special sessions. And in the recent past, the legislature has simply, they call it gaveling in and gaveling out. They have convened and said they've opened the session and then immediately closed it within 30 seconds. So simply the call for the session and the act of opening and closing the session does not necessarily mean that any business gets done. And we've seen that happen quite a few times in the last, I'd say, 8 years, last 4 sessions. But as you hear about, like, I'm calling for this special session, that is a power that the governor has, but it is also up to the legislature to decide whether or not they are going to actually conduct business in any session that is opened. Moving to Congress, one slide on Congress today. That's it. Last week we were not in a military operation in the Middle East, and this week we are, as well as it appears in Ecuador as well. So there's a lot of attention being paid to that conflict at the moment, at the expense of everything else. The partial shutdown of the Department of Homeland Security continues. There is more recent reporting this morning that the military conflicts that we are in may lead to another supplemental funding request for the military. There's now some more chatter about, well, maybe we should put that into a reconciliation bill. So, we keep having this conversation of another reconciliation bill. Is it alive or is it dead? And every time we declare it dead, there's something that happens that like resurrects it a little bit. And I think that is a conversation that we can perhaps hear more about in the next week as these conflicts go on. What is the amount of money that's being requested? I think that's a question Congress has, as well as what is the vehicle to do it? And can you do a reconciliation bill in which you might pack in a whole bunch of other things, including spending cuts to offset the increases for military spending? A lot is unclear at this particular moment, but the conversation is about those types of parameters. Also, we just got done approving federal budgets for the year 2026, and we're on 2027. Senator Baldwin happens to be on the Appropriations Committee. So if you are a Wisconsin citizen, she has a role in determining, what are the budget asks. And you can use the link that's on this slide to submit appropriation requests. And there's kind of two paths for that on the site. Like, you can talk about existing programs that receive federal dollars that you think are really important. DD councils, funding for P&As, those are examples of things that directly support organizations that are doing disability work. Lots of Older American Act programs for those of you from an aging background. Anything that is receiving federal funding now that you think should keep receiving federal funding, that is the type of thing that you can emphasize to the senator at this point, that's already part of the federal budget. And you can also make additional suggestions for federal money for certain projects or new federal money. It is likely that the president's first draft, so to speak, will be coming out in late April. Last year, it came out in late May, which was usually May is about the right time frame, but this time it'll come out in late April, and we will take a look at that because, again, while Congress may not choose to do all of the things that is proposed in that the president's version of the budget, it is a strong signal about what kinds of things the president and administration thinks are worth more money or should be cut. And it is something that Congress starts from. And as they, work on the next year's appropriation throughout the summer. All right. There's been a lot of activity in the federal administration, and a lot of it has been focused on Medicaid and specifically home and community-based services and other disability services. But I'm going to give you a little primer here. Um, Throughout the last year, we have been saying that the Office of Management and Budget has been behaving very differently than it ever has before. And that has included impounding money. In other words, not sending money to states or programs or whomever is supposed to get it that Congress has appropriated. It's also meant some funding has been frozen. Um, Sometimes it's meant grants, the applications have been changed, or who has gotten, the grant process has grant money hasn't flown through like it normally has. And this is an example where Congress actually did not cut funding for lots of science-based programs. Most of the stuff in this article is really talking about programs that are in the National Institutes of Health and other federal agencies that fund a lot of scientific work. There are a lot of studies in the National Institutes of Health that impact aging and disability, but this is kind of more of an overall statement that even though Congress deliberately said, no, we're not making the cuts that you have asked for, President, and you made actual reductions in these places without asking us last year, we're gonna restore the money and tell you to spend it. It looks like they're not doing that. That they are using a set of administrative strategies that are delaying and preventing the release of these funds. And that looks like a number of different things, that new grants aren't getting funded, that you have grants that are already funded where the payments aren't coming, and that certain kinds of projects that are not competitive, meaning like the same person who got the money before is the person who's supposed to get it again. And I'm using person very loosely here. It's often like a research institution or whatever are being held up. That's a continuation of a pattern that we saw throughout last year. And for many places that really have relied on federal funding, you have a set amount of time to spend federal dollars. So even if these folks have like money that they haven't spent yet, the longer these things are delayed, the greater the likelihood is that they run out of money and have to stop or fire staff or just, get rid of the program because there's no more money to run it. So these delays have a real tangible impact. They also mean that if you are waiting on money to hire or pay, students or interns or whomever, it's not coming through and you can't do those things. Similarly, we've talked about this a couple of times. Congress actually said in a report, not and stronger in the case of the Department of Education, they actually did put some words in the statute that was passed and signed into law. They said, hey, you don't have the ability to, Department of Education, to decide that you're going to take duties that are assigned to you under the statute and give them away to another federal agency. It does not appear that the Department of Education is really listening to what Congress said there. And we talked a couple weeks ago about, hey, they have two new interagency agreements that are transferring, again, parts of their agency's work elsewhere. Not specifically services that impact students with disabilities yet. And that was the major tone that we kind of were talking about last time. But I think it's notable that the congressional language and the clear intent in the report, and even the words, which I don't think advocates thought were as strong as they could have been, that isn't enough to stop this agency from moving forward on their plans. And Congress is not yet objecting to how the agency going against congressional intent. So again, we have now a similar pattern of Congress says one thing, but the administration may do another, and Congress is being kind of silent when they do the thing that Congress said not to do. If you think that we've been talking about kind of the same stuff for a long time, you're right. We've talked about many cases and lawsuits that have been filed really revolving around the federal government not sending money, stopping money it shouldn't have stopped, other things. And some of those programs have been directly impactful to people with disabilities. And there's a lot more um, that have had experienced the same administrative issues, but they've just been focused on non-disability or aging items. So if you think we've been talking about this a lot, they've been sued 198 times for withholding funding that people who are suing the federal government said shouldn't be withheld. And mostly courts have agreed with the people doing the suing. In other words, the courts are saying, yes, the federal government really should not be withholding funds or stopping funds. You need to send the funds as Congress appropriated. Um, but it isn't stopping the pattern of behavior. And I think the other things that is worth noting here is the 198 times the federal administration has been sued represents the folks who had the means and the ability to file a lawsuit. There are certainly many more instances of money that never got to where it needed to go, or grants that were changed where somebody who was eligible didn't became eligible, whole programs where funding was blocked. There are many examples where the people who didn't get the money didn't have the resources or the ability to file a lawsuit. So kind of look at this as there are 198 cases out there, but that does not mean there were only 198 actions that resulted in federal funding or administrative changes that have changed, either stopped or changed what Congress appropriated. So I moved this slide here. It's a familiar slide. And again, this is about what is Congress doing to provide, now that they've passed a budget, and now that we can start to see that the pattern of behavior is not changing, it really does become a question for Congress about what are you going to do differently to make sure that the things you worked really hard on and all voted on together actually happen. What are you going to do if your state is one of the victims of administrative delays or decisions? What are you going to do if the money that you said should be spent in a certain way isn't? And these are questions that are familiar because this is a pattern of behavior that is now ongoing. And I think that there are some advocates that are saying, if you can't trust that what the federal budget is translate into what is done, then it means anything that is funded with federal dollars might not be as stable as we have always assumed it to be. And I do think in this coming year, that's a real question of if Congress appropriates the money and then the administration can do or not do with that money, what does the federal budget really mean? It doesn't serve as a guarantee that the things that are in that budget actually are funded and happen. And I think that that's a situation we have never been in before. Moving on to some of the more serious messaging and actions that the Department of Health and Human Services, and specifically the Centers for Medicaid Services, are taking. At the State of the Union, you may remember that the president very briefly assigned his vice president to be the kind of person heading a war on fraud. And in that State of the Union speech, he also referenced specifically immigrants as being perpetrators of public benefits fraud, largely interpreted to mean to include Medicaid, and went so far as to say, well, if we addressed all of the fraud that's happening in these programs, then we could balance we wouldn't have a deficit anymore, which, I'll let you sit with that. So there's certainly been a lot of rhetoric in the last year about fraud, waste, and abuse, and kind of seeding the ground that somehow the programs that we have that are set up to primarily serve low income, poor people, and disproportionately people with disabilities and older adults are somehow full of fraudulent behavior, even though the evidence says otherwise. When you look at how many payments are happening and how many of them, I think it's like 94% in Medicaid, are absolutely not fraudulent. They are what they are. We have a very small subset of mistakes. And in that grouping, there is some smaller subset still that is potentially fraud, which is investigated not only and prosecuted not only at the federal level, but also at the state level. What we're seeing this week is kind of a acceleration of using the narrative that fraud is any presence of fraud means that programs should be either cut deeply or money withheld from them. And specifically, the Centers for Medicaid director is kind of on the front and the face of that argument. He's producing a number of direct videos that I think the strategy is they are hoped to be shared kind of online and get people to buy in that the administration's actions are in fact related to fraud, which we see differently, and also that this is a big problem that exists. There's also kind of an election cycle component to this. That idea of connecting some fraudulent criminal behavior with the reason of that's why healthcare costs are high, or that's why you can't find a provider, or that's why things are hard for you. I think that's an effort to draw a line between those two things, which are not true. And they also are a strategy to try and say, well, which we have heard before in the last year, well, these cuts aren't really going to impact anything because all we're cutting is fraudulent behavior where we shouldn't be spending money anyway, right? And that's why your healthcare costs are higher because there's so much fraud. So there's a couple of political messages and connections that are trying to be made here. But what is actually happening is more than rhetoric. It is actual impact on the people who are providing and getting paid to provide services. And of course, the biggest impact is the person who relies on that service whose care may be jeopardized because of funding freezes and cuts. So I put a direct link to the press release that CMS put out last week. And just some of the rhetoric, I pulled a little of the rhetoric from that release into this slide. CMS has announced several new ways that it is targeting fraud, and we will talk about they are kind of accelerating the implementation of some of what this press release has said at the moment. You can see again from the press release the connection of, hey, fraud is draining lots of money away from people who pay taxes. In other words, you as a taxpayer are being hurt by these actions. And, you can see a reference to we're going to use AI tools to decide whether something is fraudulent or not, Remember, a lot of what are considered improper payments aren't fraud. They are often mistakes. Something as simple as somebody forgot to sign a form, that would be an improper payment. Um, so this idea of connecting any type of mistake as potentially fraudulent is really is not true. Fraud is a criminal act. If you're identifying anything that could be a mistake, you can identify a potential improper payment that can be corrected. But that is not the same as saying those improper payments are fraud. And I highlighted the sentence that is a quote from this release because I think it's just really important to kind of hear how they're thinking about these actions, that these kind of, if we're going to stop Medicaid funds, who do they think that hurts? Medicaid is paying lots of different kinds of providers who are paying the workers who have already done the work. And that work is helping people who rely on those services, namely people in Medicaid, which includes a lot of people with disabilities and older adults and kids, right? So the idea that you're going to stop payments and it's only going to hurt providers who are criminally committing fraud is not correct. And also, whatever money you stop paying and work that stops getting done, it doesn't only hurt the provider, it hurts the people who are relying on those providers to exist to provide care. So this sentence about we're catching people right away, freezing out their money, and we're letting them starve. That's pretty stark language. And it implies that they are able to do that with some certainty, and that is not what we are seeing is happening. Already, CMS has deferred, and we'll talk about what deferred means. It means they're refusing to pay already submitted claims for work that has happened in Minnesota. So when you think about that last quote of we're stopping payments to starve people out who are doing wrong things, there's $260 million of submitted claims that are now not being paid in Minnesota. And the rhetoric CMS is using is some of these are questionable claims. Maybe some of them are improper payments. So we're not going to pay any money for those things until state you do a bunch of work and prove that those claims should be paid. And while you're proving that, there's no money coming in to the person who has submitted the claim for work that's already done. Also important is where did they stop the payment of those claims? What claims did they stop serving? They have been looking at where is there unusually high spending and rapid growth. And guess what? Personal care services and home and community-based services are the areas that were identified. We talked about last week the selective release of Medicaid data, again, kind of trying to focus personal care and home and community-based care as being connecting those dots, that these are places where there's high spending, pre-spending, so there must be some suspicion of fraud. There's also a lot of more people who need that kind of care, and that care is constant and needs to be provided routinely over time. So yes, there is more spending there, always has been. And yes, there is more growth because more people need that care. Not only is Minnesota not getting paid this $260 million in now, CMS has also said, we're going to keep doing this and has told the state, we will defer more than $1 billion in federal funds from your state in this next year if you don't prove that the reimbursement requests are allowable. And here's a bunch of changes that we're going to tell you you have to do to our satisfaction before we will consider whether or not to reimburse those claims. There's a deeper dive about the process here. There's actually two things happening at the same time to Minnesota. Um, January 6th, they got a letter, and they were told, CMS told them that they were going to withhold 515 million. Withhold means we're not sending money to you. And an even greater amount for the next year. And notice that there's language in here saying this amount could be bigger than that, depending on whether we think there's fraud or you haven't made the amount of progress that we think you should make. So this is pretty significant. Like the federal agency is saying, we're withholding and we get to decide when you've met enough criteria that we will stop withholding. That really puts the power in the federal agency. And again, we'll stop withholding when and we're focusing on 14 high-risk service areas. Guess what? Those high-risk service areas are the same are things like personal care and home and community-based services. Those are some of the things that are on that 14 service list. This is in addition to the deferral that we just talked about on the previous slide. So one of these things is a compliance action, and it should be noted that actually the state there's a process to reply, which the state has done, and there's supposed to be an administrative hearing with CMS, which CMS has not scheduled. And in fact, there is a time window for that administrative hearing that has not run out yet. So these actions are happening to Minnesota, and they're not following the established administrative processes that exist to kind of argue about the details. CMS has simply said, this is what we're doing, and we are in the right until you prove us not to be, until we say. And the deferral is actually separate. So that means that these two things happening together really have the ability to totally destabilize Minnesota's Medicaid program and their overall budget. In fact, the way they're doing the deferral is actually going to impact the state even more, because the way they withheld the money means that the state actually owes the federal government for that first quarter, that 260 million for the first quarter of work, and they won't see another Medicaid payment until that halt is lifted. So if nothing happens, that will directly impact the Minnesota state budget deliberations. And their state budget director is saying, hey, there are 14 services on their list, and remember, a lot of them impact people with disabilities directly. It would cost us $2 billion a year to fund those services using only state money. Spoiler alert, they don't have enough money to do that, and they're not going to. Number of Minnesota disability advocates see that connection and, are pointing out that, these actions by the federal government actually have a direct impact on the people who rely on those services, and that the impact can happen fairly quickly. Yes, Minnesota has also sued over this. I don't know if that ticks the article we covered earlier to 199 cases, or if that was already in the 198. But of course, they're suing about this. The problem is the courts have never been the right remedy for this kind of behavior, because it takes a long time to have a court argued. And even when you get a favorable ruling, there's always an appeal process. And so the reality is that, yeah, the withholding of Medicaid money is happening right now. And that means it impacts providers who are waiting to get paid again for work they already did. And it's impacting the people who rely on Medicaid in real time. And it's influencing whether those providers can afford to keep taking Medicaid patients and or stay in business if their budget is reliant on Medicaid. So a court case that takes months or years to resolve about this particular spending decision, as the federal government is saying, and we're going to do more to you, that's going to cost you more money, really isn't going to resolve this issue. And of course, you can always lose a court case. And if Minnesota lost the court case, then, we're right back in this current scenario we're in where lawmakers have to decide whether to put in more state funding or cut services. CMS has also announced a stopping of enrolling new durable medical equipment suppliers for the next 6 months. It applies interestingly, all initial enrollment, so new companies, and also changes in ownership for those companies. So that means that some of the existing suppliers that we have, whatever they're interpreting as a change of ownership, might put them on this list of you can't do these things anymore. You can't be a Medicaid provider anymore. Again, the rhetoric being used is that we're not letting in new providers because we're trying to prevent, fraudulent Medicare billing. Well, wait a minute. The way you prevent fraudulent Medicaid billing is to reform the system that you have, right? Like there's an you have to there's an assumption here that somehow a new provider is more likely to be somebody who fraudulently bills when they haven't been able to bill at all because they're not a Medicaid provider. That seems a little bit unlogical, right? And they're also telegraphing, well, we're not letting any new people in or people who exist who have changed their ownership in a way we are looking at significantly. And while we're not letting new people in, we're going to we're going to find more ways to prevent fraud. And everybody should see that sentence and go, oh, flag. CMS may be looking at their existing rules and processes and trying to find a way to make it either harder to prevent fraud, to do fraud, and or make their processes harder to do so that there are fewer people who are able to do it, and choose not to be either do this work or choose to only bill for the things that are safe to bill for, and that they know that they will get reimbursed to do. As part of that, they're also telegraphing we want to make new federal rules and soliciting ideas about how we should make a rule that all states have to follow, that would prevent fraud. Again, thinking about how some of the policy language has been structured in things like HR 1, when we have seen, people trying to connect changing process with the prevention of fraud, oftentimes that has made it much harder for people to do things correctly. And when you can't do things correctly, you kind of get kicked out of the program or not paid. So this is really something to watch, and just know that there may be some appropriate things that should be changed that would make things clearer and maybe reduce the amount of improper payments and maybe make it easier to, detect what is truly criminal from what is a mistake. That could be real, but there also can be this linkage of, oh, we're doing this because, and we're saying it's about fraud, when really we're trying to figure out how administratively we make it easier to deny, to not pay claims, to limit, the kinds of care that people can successfully get. And, as the Centers for Medicaid director has been kind of out in the public sphere talking about fraud and talking about states, he tends to be talking about the states that President Trump mentioned, specifically in the State of the Union. President Trump mentioned Minnesota, and connected that, the linkage again of fraud, immigrant, Minnesota, Medicaid, and mentioned several other states. California was one of them. I think there were two others. And specifically, now you see the CMS director also doing videos from the states that were mentioned in the State of the Union and pointing out and basically connecting a suspicion to fraud with those states. So the important piece in this article is that the CMS director honed in on in-home supportive services and supportive and home health care as the places that they think fraud exists. And again, that association of, hey, there's more spending on home care services and more providers providing those services as a suspicion for fraud. Those are two illogical things that are being connected together, but it is an excuse that is going to likely result in cuts in services. And this particular article went farther, where the suggestion that there's a robust system of home health providers in one state that may be meeting, Medicaid is a state by state program. States have a lot of ability to choose who can get into those programs. Um, they may have very different populations with different needs. They provide different services. They choose how to fund those programs. So, for example, one state might choose to fund a home health care provider at a higher rate because they see that there's a need for that service, and they know that those agencies and their workers need a higher payment rate to be able to stay in business or to retain employees. That's a very logical, argument that states debate all the time. How much do we pay to make sure that there are enough people willing to do those services? And we often complain that we don't have enough of those providers and workers to meet the actual need. This person, the CMS director, is trying to say that those states that have made decisions that have resulted in more capacity to provide these services is a sign that there's fraud there. And also, well, if you're spending more in your state on these things, then we think you're taking away funding from other states that could provide care. That isn't how Medicaid works at all. Not at all. Every state is making their own choices, and they get reimbursed by the federal government based on the systems that they've set up. There's nothing saying that a state that doesn't do much in home and community-based services now doesn't do more in the future, and they would get paid more for that. So this idea that somehow states with Medicaid programs that are more robust, that serve more people, that do more things, that pay more for certain services that people need in their state are somehow taking away from other states that have made different decisions is wrong. And also, it is wrong to say that those states should be, that they are spending more than they should. They are setting up a system that is designed to support more people, and other states have not made the same choices. The other piece highlighted in this article, we have talked a lot about the volume of care that unpaid family caregivers are already providing to make a care plan work. None of that is reflected oftentimes in, the rates. It's just work that is assumed to be free that saves the state a lot of money. And in many states, there are ways that caregivers can be paid because states have recognized it's better to pay family members than it is to go without care. The workforce crisis is so big, there aren't enough paid workers to hire. The CMS director is highlighting personal care, any kind of activities for daily living as things that your family should do for you for free. And that somehow the government should be paying for those kinds of services. And that somehow if the government is paying for those kinds of services, it means some unethical person is taking advantage of the system. I have a lot of things I'm thinking, but that's not how any of this works. And those of you who have spent a lifetime with members of your own family doing all of the things that you aren't getting paid to do, you're already doing the work, and this is indicating that families should do it all. A lot of people don't have families, or people who have family members that can't do it all. And that's what our home and community-based service system is about. How do we support families as much as we can, even if it's not 100%, to make sure that the person has the care they need to be able to stay in their home and out of an institution? And this CMS director is saying, well, if we're paying for any of that stuff, it's a sign of a problem and that the family isn't doing it. And they should be. There are lots of other states that are in line to have a similar experience to Minnesota potentially. New York got a letter from CMS requesting a lot of information, again, about how do they look for fraud and provider screening, same kinds of questions that we're seeing in Minnesota. Again, notice what kinds of services are specifically listed in this letter. It's unclear what the analysis is, except, we keep seeing references to, hey, there's certain services that we pay a lot for. That must be an indication of a problem. Personal care, home health, daycare programming, non-emergency medical transportation, and behavioral health services. These are all home and community-based services. They all disproportionately support people with disabilities and older adults, and they are all services where the person who needs them likely needs services consistently over a long period of time. And you can see that the letter is being used to say, to equate, you pay more for certain things, New York, and you have more people using your services. So because you pay more for your Medicaid stuff and people use it more, that must be a reason to suspect fraud. Also, looking at, you have more benefits and better pay for your providers in your state. That's a reason your spending's too high. Again, New York's designed a system that it thinks it needs for its particular population, and it's decided to offer more benefits, and it's decided to provide providers with more pay, and it is providing state of New York taxpayer money because, again, Medicaid is partially funded by the state and partially funded by the federal government. And all of the people in New York are also federal taxpayers. So some of the money that they are paying in for federal taxes is coming back to New York in the form of federal dollars for Medicaid. This is an indication that we're watching that a similar experience to what Minnesota is now experiencing could be in line for this state too. And they're not the only state to receive a letter. At a congressional hearing this week, CMS is apparently testified again to Congress. Oh, here are all the Medicaid services that we think are experiencing a lot of fraud. Applied behavioral therapy, autism services, non-emergency medical transportation, home and community-based services, lab, substance abuse treatments, hospice, all of this stuff. They have just told Congress, hey, these programs that lots of people use that are experiencing increases of spending, they are now equating that with fraud to members of Congress. Every letter seems to have some themes, and one of those themes is, hey, you states are being too generous with who you've decided can be in your program and your services. Here are the states that have already gotten a letter: Nebraska, Pennsylvania, Oregon, Maine, Colorado, Washington State, Massachusetts. We already talked about New York and California. Look at all of the things that are listed on here. You see HCBS mentioned 4 times. ABA is mentioned a couple of times. NEMT, behavioral health, personal care, home health. These are all the services that serve the same kinds of people. Moving to the reconciliation bill, we're starting to see more and more states kind of ramp up, where they think they can trim off dollars before they get into serious cutting. This week, Iowa is in the news, and states, we keep saying states have really options to reduce Medicaid budgets, decide to let, you can make people wait to get in who are qualified. You can decide fewer people should be able to get in, right? You can change or reduce the number of services that you offer. You can pay your providers less, or you can pay more state money to cover the gaps, right? But that is an unlikely option. This is a slightly different technique than what we have seen in other states. Right now, we have seen states propose to eliminate services. We've also seen states propose to change their eligibility requirements so that fewer people get in. And we've seen states decide to make cuts to provider rates. This is different. And it's a little more undercover. It looks like the cuts are happening kind of on a person by person basis, through, cuts to individual plans and maybe some state administrative rule changes, kind of quietly just reducing the amount of services that are being provided, which does have the effect of suppressing how much is being spent. When you have a care plan that, say, is funding 20 hours of personal care a week, and all of a sudden that plan is funding 10, you're not paying for the 10 hours that you cut anymore. That is a savings to the Medicaid budget. It may not end up being a savings if the person that needs those hours goes into a hospital because they're not, able to get the care they need, or they have to live in an institution. But, overall, if you're looking at how many hours are we paying for, if we paid for less of those hours, we spend more on those hours, that's true. And it appears that multiple families are reporting that they are going to have their plans be cut in the future. The family that's featured in this article is a nonverbal person with several disabilities. And his family has been notified by the private company, so probably a managed care organization that is contracting with the state of Iowa to provide those services, that they're going to cut 40% of what they're currently paying for caregivers out of his plan. And this is another approach. It's a more administrative approach that a lot of advocates are expecting to kind of quietly ramp up across states as they're trying to figure out how do we respond to reductions in federal spending. In Idaho, This is the state that has already said maybe we should eliminate home and community-based services entirely. Um, these advocates have been forced to be tireless all the way through, but now are again putting themselves out there just like a lot of you have over the last year to really connect the dots and saying the reduction of these dollars translates into my person not surviving. And they excuse me. They are really on the front end of this because this is a state that has already made some cuts and is now proposing eliminating entire service categories all before, the cuts that are coming from HR 1 are taking effect. Just a little more about Idaho. When you think Wisconsin covers about 1.2 million people in our collective Medicaid programs, and Wisconsin gets about 60% of the dollars that support those Medicaid folks are paid for by the federal government, 40% comes from the states. That ratio can change from state to state based on a number of factors. So you look at what's being cut in Idaho. There's 300,000 people in Idaho who are in these programs. I believe they have a waiting list for services. So not everybody who had need is getting in. And 80% of what pays for Medicaid in Idaho is coming from the federal government. There's a $22 million gap right now. Their legislature is not willing to use any of their reserve to fill that gap. When we have talked about the idea of reducing revenue, i.e. tax cuts, putting states in a worse budget position to respond to increasing costs or a down economy or other things, this is an example state here where they keep cutting taxes. And over the last 5 years, they've reduced the amount of revenue coming into the state by $4 billion, over in 453 million in the last year, and they don't have money now to respond to any of the changes that are coming to HR 1. So you can kind of see a spiraling and a ratcheting down of what these programs are, and not a lot of political will to undo some of those decisions. This may not even save money for Idaho. Rightly, advocates are pointing out that even though home and community-based services are optional under federal Medicaid law, the only reason states are allowed to have them is because you have to prove that they're cheaper than care in a nursing home. So every state that has gone to home and community-based services, and every state has, it has been because they have figured out actuarially through financial tables that doing those things is a lot cheaper option for them than nursing home care. So cutting there, even though you kind of can because under federal Medicaid law it's allowable, just means that the people who can't get care in their homes now are pushed into more restrictive settings that may not have room to care for them anyway. And again, families are making a very clear, direct line of if this, then that. And in this case, it really is if we don't get these services that we have now, he's going to end up here and he will die there because we know he cannot get the care that he needs to be successful. Another optional benefit that is being highlighted at risk, lots of people in Wisconsin and many other states have talked about how hard it is to find a dentist and to get preventative tooth care. And we have plenty of stories of people who, because they can't get in to see a dentist, don't get the preventative care and end up in pretty significant medical situations or tooth extractions because things that could have been addressed early progress into deep tooth infections that then go into systemic infections and otherwise. There's a reason most states have said, yeah, dental care is actually a good benefit to have because it is important to overall health. Um, and it is, again, a service that is not necessarily required under federal Medicaid law. Um, it's required for kids, not for adults. That is optional for states. Adult dental care in Medicaid is optional for states. Most states do it except for Alabama. Um, but lots of states have limited or emergency only care for adults. And this is a service that is being identified as, again, another easy place where it's optional that folks can cut and just say, no, we're not, we're changing the benefits so it's far less useful, or we're eliminating it entirely. A bigger analysis of what is coming from the $1 trillion of Medicaid cuts in HR 1 and how it's going to impact states. This is Becker's hospital review, and it's projecting that states are going, state Medicaid budgets alone are going to lose about $664 billion through the next 8 years as the various provisions of HR 1 take effect. And at the same time, the forecast for, how much money states are going to be collecting that they would have to perhaps fill some of those goals is also shrinking at the same time. So in other words, big hits and big reductions in federal money and less coming in for states. Nothing to offset those cuts. Obviously, some of these impacts vary state by state because, states have kind of come up with different ideas about how to fund their Medicaid programs. We have been focused on the first impact that is coming, which is the prove you're working or exempt requirements. But there are things that are in HR 1 that will be hitting after that. And they will have their own pile-on impacts to states. In other words, we're taking our hits now before we get to even a state budget process. Then we're going to take hits from prove you're working or exempt requirements. At the same time, we're taking more hits in the state budget process. And then some of these additional pieces of HR 1 are going to continue to add on and deepen those budget troubles. Wisconsin has not used provider taxes as much as most other states to fund their Medicaid programs. However, it is unclear whether CMS will approve our recent raise of those provider taxes to the level that they are capped now under HR 1. So we're not out of the woods in terms of we raised it to the threshold thinking that that would draw down more federal dollars. And CMS may decide that they don't want to give us those federal dollars, which would create a hole that we had not accounted for, $792 million hole. But for a lot of states that use that funding mechanism, they are poised to start really feeling big dramatic reductions because of the new caps in HR 1. And then there's another provision that really is aimed at states that have kind of upped certain rates to ratchet down those rates to be more uniform in the future. Just to give you a scale, 20 states expect to see Medicaid budget reductions of 5% or more. Well, what is 5%? That doesn't sound like it's a huge amount of money. For most states, the Medicaid budget is at least a quarter, if not a third, of what the state spends its entire budget on. So a 5% reduction in, say, a $20 billion budget is a lot of money that states don't have the ability to cover. And for some states, it's going to be a bigger reduction, 15%, um, more than 15%. Um, California and New York, who have some of the bigger populations and probably have more people in Medicaid and are also maybe have systems that cover more. You can see how much money they are poised to lose here. And also projected in this is the amount of enrollment, like who's in Medicaid. Declining enrollment means there are people there's a number of people who are getting care now, and it's going to be a lot less in the future. 20% in some states, almost 40% of the people in Medicaid now won't be there in others. Um, States obviously are going to try and address these financial situations in different ways. That's hard to predict. But what the study is clear on is that of all of the money that they are going to lose from the federal government, all of the big budget holes that are created, only about half of what's going to be lost at the best case scenario is going to be picked up and covered by state budget dollars. So that means there's a whole lot of reduction and money being taken out of the system that is not going to be replaced. And that means loss of coverage, providers, services, people who cannot get care. Um, about a third of the spending cuts are going to be are projected to be from people who are not in Medicaid anymore. So in other words, people who lose access to care, either lose what the care they have or can't get in. And then 2/3 of those dollars that aren't getting replaced might come from provider rates being cut. A different survey, this surveyed 9 Western states, um, and said, hey, what are you planning to do specifically about disability services? So they sent out the survey. They got responses from 9 states, but still 9 states out of 50 in the West. You can see that 2/3 of those states that responded said that the provider taxes are a way that they fund disability services. So the fact that those provider taxes are going to be ratcheted down is a direct impact on the services that impact people with disabilities. Almost everybody is saying they're going to reduce services. And again, they are listing, here are the services that we're thinking about first. They aren't necessarily the services that the Centers for Medicaid director is pointing out as, trying to connect, hey, there's a lot of high spending here that could mean fraud. These are more specific services, but they're still all the things that people with disabilities use. Lots of states are exploring different ways of cuts, um, service reduction levels, maybe multiple options, including service cuts for current enrollees, provider rate cuts, or limiting who can get in. Um, there's only one state that said none of those reductions were going to occur. So, across the board, with the exception of one, most states are feeling like pretty likely that we are going to do some combination of things that is going to directly impact this population of people who probably rely on the most services and need the most care. Um, and it's important to remember that when Congress was debating this bill and making $1 trillion in Medicaid cuts, they specifically said these groups of people, older people and people with disabilities, oh, this won't hurt you. There's more and more evidence out there that that is exactly who's going to hurt. And part of our role here in sharing some of this information is because we're hoping that you will also share this information, and kind of help do some work in real time to let our own state lawmakers, who will be the ones in charge of making these decisions, and also your friends and neighbors, know what kind of impact this is going to have on the community. We keep talking about provider rate cuts. It's really important to know that that's the amount of money that they are getting paid to do the work. And if they aren't paid enough money to do the work, they're going to fire workers or take less people or go out of business. Like, there is a community impact that Medicaid has that is, not only related to the people who are in Medicaid, but also the whole community who needs businesses that are employing people and paying them to go out and spend money in other stores. This is kind of a ripple effect that nobody escapes here. Um, the money that's being cut, I think we've said this a couple times, it isn't going to be replaced, or at least not all of it, with state funding. So I think that's another line that we heard from Congress in the last year is like, states are going to make those decisions. It's up to the state to do that. They can choose um, to fill in any federal cuts that happen. And we all know that states don't have enough money to do that, and they may not want to choose to do it anyway. But again, reminding Congress also of what they said and what's actually happening is really important. Meanwhile, the first thing that's going to happen is those work requirements. We've covered this topic before. It caught like some of the new requirements in HR 1 aren't only about Medicaid dollars being reduced that are coming to states. It's also about making states spend more to run Medicaid. So a lot of states are going to have to significantly upgrade the number of workers in their technology here, in order just to meet the prove you're working or exempt requirement. And a lot of those systems don't collect data on important things that might make the difference between somebody being exempt from the work requirement or having to prove that they're working enough to keep their health care. So things like, can we easily understand if you're employed or you're a student? What do we do about volunteers? Because there's no way to track that right now. How do caregivers prove that they're exempt? How do they prove who they're caring for and how much care is necessary, and those types of things? The feds aren't providing rules about this stuff yet. They're not required to until June. And there's some really important folks, important exemptions where there's just not any clarity right now as to how you fit into the exemption. And we've talked about this in relation to SNAP. There's another provision coming in from HR 1 in 2029 that is going to impose a penalty for states that don't do enough of this stuff right enough. So while we've been talking about all of the pitfalls that are still unknown about how do you set up and how do you finance and pay for a new system to implement the prove you're working or exempt requirements, if you don't have a system that's good enough, you may end up with penalties that are going to cost your state Medicaid money in less than 3 years. And again, we've talked a lot about this idea of fraud. The Medicaid payment error rate measurement is a measurement of improper payments. Again, improper payments are not fraud. It's usually a measure of how many mistakes are happening on paperwork, right? And they use this measurement to say, okay, how many of the total number of reimbursements have a mistake that makes it an improper payment. So the original purpose of this program was to help states reduce their errors. It isn't a measure of fraud, but beginning in 2029, because of HR 1, states that have error rates that are greater than 3% are going to have to repay some of um, the federal portion of however many improper payments above that 3% that they have. The other change is HR1 changes what's considered a mistake and makes it easier to make mistakes, right? So that form that doesn't have the doctor's signature on it, that is now, it is considered an improper payment because there's a mistake on the documentation, but now it's going to be included in the errors that could lead to financial penalties for the state. Um, Almost there are lots of states that have error rates above 3% right now. Almost 25% of the states, if something doesn't change and this provision goes into effect, will be on the hook for repaying the federal government for a certain amount of states. And the Congressional Budget Office has estimated that that could mean that states, when it says they're reducing federal spending, well, really what it means is that states are paying the federal government back almost $7.6 billion in the next 10 years. So it could be pretty significant on top of all of the other things. This is a very similar policy strategy as to what we've seen in SNAP, um, which is also in HR1. And we've spent more time talking about SNAP, but this is also a similar idea of we're going to look at your errors. And if you have too many of them, we're going to make you pay money back to the federal government as a condition of the program. Similar policy strategy. And that is it for this week. I feel like that's enough.
It's a lot, but you covered it well. We don't have any questions in the chat, so thanks, Tammy.